Testing, testing.
Works well.
Hello, Victor.
Hello, Michelle. How are you?
Very fine. And you? Did you have a nice holiday?
That was good. What about you?
I did. I'm no longer hospital attending. I'm just myself, so it's particularly nice.
That's good. Good.
But certainly busy time for all of us, right?
Yeah, yeah.
Good. All right. And welcome, Jennifer and Erica. You are early, so thank you for joining us. And we'll wait to get everybody on board. I see Chad. So we're getting our cohort together to talk about cohorting. All right. Okay. It is 2 o'clock and welcome back everybody to session 3. Hope everyone had an enjoyable holiday, maybe a little time off and safely and with good rest, and back to talk about cohorting today for our AHRQ Project ECHO and Nursing Home COVID Session 3. So I'm going to start by sharing my screen to go over our goals for today's session. And let me get here. So today we're going to be talking about approaches to cohorting. Dr. Namali Stone actually trained here at Johns Hopkins before she went to the CDC, and is one of the lead researchers in nursing home infections at the CDC. And she was part of the group that made this supplemental resource, a video on the CDC's infection prevention. It's a 20-minute video. I'm not going to show it today, but I want you to be aware of it. And certainly for some who have a particular interest in the real basics of cohorting, this is a great place to start. So I want you to be aware of this video, but I think for the sake of today, and I'd rather hear from each of the facilities about cohorting, how you bring in new residents to your facility, how you cohort. So we'll do a discussion with each other because it's such a small group, rather than view a video and answer questions. But I want you to be aware of this resource for additional, for those staff who can't be attending today. And of course, this session is being recorded so that those who can't be here can have access to it later. Then as part of our learning objectives today for quality improvement, we're going to be talking about preparing staff, and particularly the role of small group huddles for problem solving and hearing staff concerns. So that'll be the second part of today's discussion. So we're going to start by talking about cohorting for residents. So with that, I'm going to stop sharing my screen. And I'm going to ask that each facility take a turn one by one, tell us the name of your facility, and tell us, let's start first with bringing in new residents to your facility. Let's start with that topic. So tell us about your protocols and procedures for bringing new residents into your facility at this time. Ryan?
Hi,
Mhm.
Hi, this is Kim and Ryan from Canton.
Thank you. Mhm.
So any new resident, we have an observation unit set up with, well, they're double rooms, but they're right now single occupancy rooms for their first 14 days.
Mhm.
You know, we're doing the weekly testing as required. And then we do move them. We have 2 other units on our unit 2 and unit 3, and we kind of just put them up on one of those units to make room for others after the 14 days.
Thank you. And tell me, Kim, are you having trouble meeting the needs in terms of new admissions? The private rooms in particular must be challenging.
It is. Really, and that's actually one thing that I was going to speak about today. It's a lot of times we're having challenges if we have a patient from unit 2 or unit 3 that goes to the hospital and then readmitting. They might be ready and we might not have a room ready, but they need to come back from the hospital, you know, and of course they can't go back to their original room because most generally they would have a roommate up there, so that's not an option.
Mm-hmm.
So in one instance, we had somebody that was ready to come back from the hospital. We had people, you know, we had our 15 beds filled on our observation unit, but we did happen to have 2 patients that were on, I think, day 12, and so they were not having any signs and symptoms. So we opted to move those 2 together since they were kind of the longest in our observation, and then move them up at day 14. But we were able to make up room for the readmission. And of course, we called the health department, and they gave us their blessing about that and said that that was a good option to do. So
Mm-hmm.
just have to be a little creative sometimes.
Yeah, absolutely. Terrific. Let me just also remind everyone to put your name and your facility in the chat so we can log in all of our participants for today. So if you take a moment at the bottom there under chat, just type in the name of each individual who's participating today and your facility, because I know there's for some of our facilities you have more than one person on your video here or audio. So thank you, Ryan and Kim from Future Care Canton for your procedures. Chad, how about you next?
Good afternoon. We actually have an area in the building that we took, all our rooms are double rooms, and we made them into single rooms on one hall on one floor. And we didn't do the whole entire hallway. We just did part of it, and we divided it off with a double plastic wall. That way, if need be, if there is more admissions that we need to admit as new admits or returning ones, we can expand that wall down with some minor room adjustment moves. But again, the first 14 days they're there, and we are conducting our weekly testing. So right now we haven't ran into any big problems in reference to the quarantine unit getting full. Again, we can adjust it as needed if we can move a few other residents around. But the local hospital that we currently get their referrals from, they have a number of COVID positive patients over there. So the referrals have been very low recently. So we haven't ran into any big challenges with that at this point.
Yeah, I follow those numbers daily, and you have an impressive number of patients in your region right now with hospital care and ICU care, and many of those will need post-acute rehabilitation and skilled nursing facility. So you're a hot spot right now.
Yeah, our county positivity rate today, it came out as almost 12%.
Mhm, mhm. And again, looking at the ICU care in particular, and many of those individuals will need physical recovery in an inpatient setting, and so you're needed. So, uh, are you finding fewer referrals, or some folks? Are you hearing about individuals who may well non-COVID times have come to you for post-acute care, but instead going home with home care?
Oh,
Uh,
absolutely.
And do you think
Absolutely.
that's the reason you're able to maintain your single room for your quarantine unit?
Yeah, to answer your question on that, a lot of folks that can go home for like what we used to get, we get a lot of like maybe hips,
Mhm.
be in for temporary stay for rehab. A lot of them are going home and going outpatient for that versus coming to the long-term care facility. So our referrals have dwindled off in that aspect greatly.
Mhm. We haven't yet cut our elective surgeries this time around. Obviously, we all did in the spring. We're still moving forward here at Hopkins, but certainly wondering about whether there will be a state mandate. Um, but we're also seeing something very different now than what we saw in the spring, and that's our non-COVID medical patients are not decreasing. In fact, we have a surge of non-COVID patients. We actually think part of it is related to individuals deferring care of their chronic illnesses in the spring and summer because of COVID. And we're seeing in particular a lot of COPD and CHF exacerbations with significant debility that will need post-acute rehab. Are you seeing that in your area, Chad?
Yes, a little bit in our area with that, yes.
Mhm. And all of those referrals, then when they come to your facility, go to your quarantine unit first, right?
Correct.
Good, good.
Yep.
Okay, so we've heard from Future Care Canton, and we've heard from Lorien, Columbia, right, Chad? Lorien, Columbia?
It's Hagerstown, Maryland.
Oh, I'm sorry, Chad. Thank you.
Yep.
Sorry. Um, who else do we have today? We have Future Care North Point. How about who's on?
Future Care North Point is here. Sorry about that.
That's okay. Um, so tell us about is Future Care, Future Care Canton and North Point using a corporate approach to quarantine?
When you say quarantine, are you referring to observation?
Yeah, observation. Mhm.
Yep. Yeah, I think we're all following the same guidelines across all of Future Care when it comes to the observation units.
Mhm.
You know, anybody that comes in from the hospital or any sort of admission that we're getting is going into the observation unit for those necessary days.
So,
And then we obviously have dedicated staff taking care of them.
mhm. That's something we hadn't talked about. So dedicated staff. How have you managed to staff the observation unit with dedicated staff?
I mean, I think like everything else, you're doing it to the best of your ability.
Mhm.
You know, if staffing challenges come up, there do come certain times where you need to, you need to switch people over, but, you're doing everything within your power to make sure that those people that are working the observation unit stay on the observation unit.
Mhm. Are there any strategies you have to address the concerns of those staff working continuously on an observation unit, or tell me how you've managed those issues?
So when you're referring to the issues of somebody are you talking about concerns of potentially those observation residents bringing COVID into the facility? Is that kind of what you're referring to, or what?
No, I'm thinking about what we'll be talking about later, which is quality of life and addressing staff concerns. Is there anything you've thought of or done differently to help your staff who are assigned to the observation unit manage there, knowing that they're using potentially more PPE and have more restrictions?
Yeah, I think for us, it's a constant conversation. You know, we just continually have those staff huddles and have the meetings, and we always look at opportunities of where we can become better, become more efficient. And like we've talked about before many times on this meeting, we understand that COVID fatigue and, you know, putting on PPE and going through things day in and day out can be very tedious and can start to wear on everyone. So it's just about having those open conversations and open dialogue to make sure that we're doing anything and everything we can and really listening to the feedback from our staff.
That's great. Sure. Thank you. Terry Dean and Lisa Carter from Lorien, Columbia. I know that you're busy there in Howard County with COVID. I see your hospital numbers and ICU numbers. So tell us how you're managing your observation unit. And don't forget to unmute your microphone at the bottom of your screen.
We manage our observation unit by having set staff that work with our observation patients. We do everything we can to not float any of our patients. They are all under strict PPE protocol with isolation gowns.
Good.
With routine follow-ups of monitoring every 4 hours.
Great. Tell me, have you had the experience of a new resident in the observation unit becoming symptomatic or testing positive?
We actually have, literally just right before Thanksgiving break, we had an admission. She came in with a low-grade temp. She had a lot of underlying issues going on. Her temps are slowly rising, so we decided to do a rapid COVID test on her. Mm-hmm. It was positive. We did a second one just because that's what we do here. That's our protocol that we like to do. The second was positive. She was here in barely even 24 hours, went to the emergency room, and they did a PCR there, and she was positive.
Wow. Did she come from home or did she come from the hospital room?
Nope, she came from the hospital. Her admission COVID test at the hospital was negative. And of course, since they don't test anymore prior to discharge, came here with COVID.
And do you recall her initial hospitalization? Was it for a chronic condition that was worsened, or do you recall the circumstances?
At the top of my head, possibly UTI. That's what it was. She was anemic.
And was in the hospital just a few days, 3 midnights, or are you accepting patients before the 3 midnight rule? Or?
We do accept patients before the midnight rule.
As most facilities are under our COVID waiver right now. And so patient presented to the hospital with urinary tract symptoms, came to you for rehab, and arrived with new symptoms of COVID.
Right.
How did your, any debriefing with your staff on that? How did the staff do with that particular encounter? It's a very powerful encounter.
It is, but the fact that we treat all of them as if they might possibly have COVID, it's great to know that they might not be COVID, but then they are COVID positive, but we do make sure they treat everyone as if they are COVID positive while they're under their observation period.
What a powerful message. I mean, there it is in real life. This is why we are doing what we're doing. So very effective. So that patient went to one of your private rooms then for the observation?
Of course.
And so, and then staff who were in the appropriate PPE were caring for the patient. They identified symptoms, and you said the symptoms were fever?
Right. Well, she had a low-grade fever when she entered in at like 99.2, but the fact that she increased to like 99.8, and then she was 101, we decided to do a rapid COVID test on her just to see if there was an underlying possible that she's COVID, or is it that the UTI wasn't resolved and she's becoming septic?
Sure. Or I guess probably a little too short to have thought about C. difficile colitis. Do you recall whether that patient had any loose bowels with it?
She did not.
Did not. But the instincts are perfect. I mean, that is, you folks should have done the video for the CDC, right? Because that's, you did it. And Was there sharing with the rest of your staff, what I would call a victory in the COVID war for your facility by following these protocols?
I don't know if the other facilities are following those protocols, but it's definitely it's something I mean, our corporate office does communicate with things that we're all doing together. So if anyone else has likes the idea and wants to pick up on it, they're more than welcome to do so. I'm not sure if anyone actually picks up doing these protocols that we're doing here.
Did you share with the rest of your staff, though, and the other floors, the non-observation floors, that in fact your observation team identified a new admission who turned out to be COVID positive, symptomatic, and that you folks were the appropriate barrier for the rest of the facility?
Yeah, they are aware of that because we do clinical meeting every morning. So it is communicated with them that goes on all the units every morning. But we follow the same protocol for all units. So all unit managers are under that same policy. So the whole building follows that same those same steps.
Mm-hmm. Fantastic. Good. Any other facilities? Go ahead, Jim.
This is Jim from Columbia too. I just wanted to add, we have a lot of the same comments everybody else does in regards to observation and staffing, trying to have staff on designated units for the most part. And we periodically have had, rightfully so, staff say, they're concerned about working on the observation unit, because right there, we just talked about an example of it can happen, so it's a rightful concern. But to some extent, we talk about staff, it's maybe even safer on the observation unit. We have more PPE usage, there's more protection, more protocols in place, because basically your whole facility is an observation unit. I mean, we're monitoring signs and symptoms on every single patient, every single shift, and every single day. So, and maybe using a little less PPE on those other units. So there's pros and cons of, working on those designated units. At least, you're taking additional protective steps. And even if you're on the COVID unit, you're taking even more protective steps, because we've certainly had long-term care residents that have shown up positive that,
Yep.
Most of them were asymptomatic, or even some that were symptomatic. So they happen everywhere, not just on the OBS unit.
Exactly. You're so right, Jim. Yep. I sometimes feel safer here in the hospital than I do in the grocery store, because again, as you said, we have the PPE here, we have the protocols, and as we talked about last week, checklists of observations for appropriate use of PPE. So yeah, I think we're all more vigilant, and so that is definitely human nature. I share that with you. Mm-hmm. Any other facilities have had what I call a victory in the observation units, where in fact they've identified a patient with a new admission under observation with COVID?
Hi, it's Chelsea from Loring Mace Chapel.
Hey,
we actually had a resident we had COVID in the facility. We had a resident who had not been exposed to COVID in the facility. It was not, all the contact tracing, she was not going to get COVID, right, when you moved it through.
Mm-hmm.
The hospital actually put her in the COVID unit, which I found out from her family, that just because we had a COVID outbreak. So we had isolated her, and then turns out she has COVID. So that was a really good catch, that we were able just to get her whisked right into closer observation.
Mm-hmm. Good for you. So let's talk now about not new admissions to your facilities, but in fact, through your mandatory screening now and identifying residents, long-term care or short stay residents who test positive, and cohorting. Tell me about your strategies for cohorting residents who are positive. And Chelsea, let's start with you from Loring Mace Chapel then.
So we do cohort residents who are positive. So we have set aside one of our units for, we have our COVID rule area and then our COVID positive. We keep those separate. Anyone who's on COVID rule out is isolated, but once you're positive, fortunately, you can go into the semi-private rooms. Yay!
Right. Yep.
We try to cohort people based on your days. So like if you're positive on the same days, we really want you to be, with someone else who is positive on that day. So I think that helps a lot instead of just mixing, you have a positive who has been positive for 10 days with a new positive, just because we don't know a lot about COVID as far as reinfection, and just think that's a little easier. But,
Good. Tell me about the management of your cohorting unit in terms of monitoring of the residents.
So anytime we have a COVID outbreak in the facility, all residents are placed on a Q4-hour full set of vitals. They are supervised by an RN, evaluated by an RN daily at minimum, probably more, just depends on our staffing. Frequent communication with doctors. We do some frequent rounding of staff to make sure there's PPE compliance, although ironically have more PPE compliance on a COVID unit than you would elsewhere, because you know that it's bad, instead of that, well, I take care of my patient every day, I don't see it as much. So that it kind of helps on the COVID unit, just because people are so much more stringent with their PPE when they do have COVID.
Yeah. Sure. Okay. Let's see. Chad and Juliet, tell us about your unit for managing COVID positive residents.
Okay. We do cohort the positive residents on our COVID positive unit, and we try to make sure if we do have like an outbreak of a number of residents in a certain short period of time, that they're cohorted together in the same room to try to keep as close as possible to that date that they all tested positive. And each shift, the vitals are taken on each shift regularly. And we have more of our cream of the crop of our nursing staff, because I'm sure everybody's having staffing challenges and the need for agency. We've been very fortunate. We have a good crew for our staff, aid-wise and nurse-wise, that are on that unit, which are some of our strongest people.
Good for you.
Yeah, so we've been fortunate in that
How
aspect.
did you look at your building and your different units? How did you decide where should be the cohorting unit? What are the practical things that went into your decision?
The way the building's laid out, we're 3 stories. First story is all kind of the general offices. The second floor is was more the short-term residents, and the third floor is more of the long-term residents. The facility that we're currently at here, there was an old cafe which had like a separate entrance into the cafe area, which years ago the company had done away with the cafe. So it was kind of just there as a room, an entrance that wasn't used. So this makes it so nice. That is our main entrance in for the staff to go up the stairwell.
Wow.
The back way, yes, we're very fortunate there. And when you go up the stairwell, 1 flight of stairs, the way each floor has 3 hallways. We initially took one of our smaller hallways that had 18 beds in, which would be 9 rooms, and made that our COVID positive unit. And down at the end of that hallway, there's a big, large gathering room where we kind of made the nurses station with all the needed supplies and everything. So it's worked very well for us to make that our area. Now, just recently, we had a little spike in COVID positive cases. We had to expand it a little bit. So we were able to come off of that unit. The nursing station sits like it's a pinwheel. And we were able to, with plastic walls, add some more rooms down the other hall to still utilize that second floor. So that's how we did it. I mean, it just kind of made sense when you look at the floor plan, the layout, it just kind of fell right out there with having that old cafe that was no longer in use. So that was very, very beneficial. That's how it was decided.
So your principles were private entrance, area for staff, and storage of equipment, and then the ability to expand as your need arose. So those are all very practical and very, very creative and very astute planning on your team's part. So very nice.
And again, it's a whole entire team. We have a great director of nursing that works close with our clinical service director. So it's a whole team effort, but yeah, looking at the floor plans, it just that was the best move at the time, and was an opportunity, if need be, to expand off that a little bit. So it worked out nice so far, considering we had to expand it slightly.
Mm-hmm. Terry and Lisa, I've been to Lorien, Columbia. Tell me where your cohorting unit is and how you decided on that unit.
Our observation on COVID units actually are rehab units.
Mm-hmm.
It was easier to choose that unit just due to less patients on that unit, so it was easier to maneuver around.
So it was based on the number of beds you anticipated needing, and that was the right size?
Correct, yes.
Mm-hmm.
So it's a long straight hallway, so the back end of that hallway is actually where we put our COVID positive patients.
Mm-hmm.
We don't have very many. We've had one that recently got off of isolation, but we do observations to that first part of that hallway if we really need to, just because we have yet to actually run out of beds where we need to cohort anyone right now. So any of our observation patients, just as well if we had positive patients, we have not yet to have to cohort anyone. So we manage that as observation, and we have a certain amount of beds that stay open just in case we have any COVID positive patients.
Oh, good. I'm thinking about that space. It's been a few months since I've been there, but is there space there then adequate for your staff to have their PPE and some of the things that we heard from from Chad and Jim?
Yes. So something that we did initiate within the last couple of weeks is actual linen carts. But instead of actually having linen carts, they're gown carts. So they have a massive gown supplies throughout the unit. So they have access to a gown since they got to change them every time they go into the room. They have them available to them.
Mm-hmm. Good. Alrighty. How about Brian from Future Care Canton? It's been a while since I've been in your building. Tell me where you're cohorting.
So we're cohorting on our first floor in our B hall for observation and in our C hall for COVID.
Mm-hmm. And how'd you find those?
So recently we had to switch just due to varying numbers. I think like everyone's talked about earlier, it does kind of depend on where your numbers are at and how things go as far as what you need to do. So it does, we try and forecast as much as possible, but none of us have a crystal ball to be able to look into the future. So I think the other thing is we do have to be flexible depending on what we run into. We're lucky that our team here is flexible and understanding depending on what we run into and what we're faced with.
Ryan, tell me about the practical aspects of moving a resident who tests positive from the second floor down to your cohorting floor. How's that done?
Yeah, so we take, the first thing we do is we like to move them immediately, just with whatever they need. So we'll get the resident down, and obviously if they're able to, get them wearing a mask, get them in the wheelchair if they're able to transport in a wheelchair or, whatever other device is necessary. And so we will immediately get them down to the room and then figure out belongings on the tail end. So the first thing is getting them into the appropriate room. As other people were talking about, when it comes to cohorting residents in different rooms, we do try and look at dates. The other thing that we're big at looking at is asymptomatic versus symptomatic resident. So we don't want to cohort a symptomatic resident with an asymptomatic resident. That's not something that we do.
Yeah, we hadn't talked about that yet, but certainly that makes sense. Good. How does the word pass then? So there's a positive test. What's the chain of command, or how does it get to that nursing assistant that this resident needs to be moved?
Yeah, so the first thing that we do is as soon as we have that, we'll call the team together because it's a group effort. So we'll make sure that, EVS is notified, make sure that the nurse is notified, the GNA who's taking care of that resident is notified. So really what it is getting a huddle together of that group and then creating a plan to make sure that everything goes smoothly.
Good.
That way everyone's on the same page and everyone knows what they're assigned to do.
Great. Let me ask, any of the facilities been challenged by notifying family members and residents of these new policies for observation? Should a long-term care resident go to the hospital and come back for non-COVID reasons? Let's talk a little bit about communications of families and residents for that reason, or also the issue of cohorting. Chelsea and Erica, can you tell me about how how Laurie and Mace Chapel has been communicating all of this to family members?
If we have a resident that goes to the hospital and returns, we just let the family know that they have to go on our unit for 14 days. And when that time is up, we move them back to their long-term care bed as long as, they have no symptoms and everything. And for the most part, our families have been okay with that.
Great, good.
We also do a lot of family emails as well, just to kind of send out any changes in policy that they might need to be aware of. We were limiting certain types of food being brought into the facility or flowers coming to the facility. So it kind of just we try to hit it lets us get all of our family members pretty quickly. So that helps as well. And we can do that with the positives, because especially for staff positives now, with everybody's county positivity being so high, it just would, you get sick of the phone calls. When I had my first outbreak, they were just like, okay, thanks. I'm over the call. So I think the email's the easiest way for those kind of big messages.
Good. Good. Chad, have you been communicating with your families over cohorting and then observation status when residents return from the hospital?
Overall, we have not had a lot of, I don't want to push back from the families. It's more if we just communicate, which we have been regularly with our cases with a letter each week, but with the nursing staff along with the social service department, you always have your few families that will, continue to question about their loved one and the move. But once they just hear the story and what we got to do and follow the guidelines, it always 99% of the time has a great outcome. So it's just about communication, key communication.
I think here in Maryland, we've been particularly fortunate by having strong government leadership, and I think our news media has also been communicating what regulations, what the Department of Health has not advised, but mandated. And so I think that makes it easier as well.
Yes, I absolutely agree with that, because we do get a lot of compliments back from the family. Just, we're thinking about you. We appreciate the communication. Even from some of the challenging families, it's been surprising with the great comments, and they're very supportive. And I think you're right with Governor Hogan and the orders that are out there. It seems like it's real prevalent to them that they more or less have an understanding, but there's always one or two we just got to communicate a little more effectively with, and it's had a great outcome so far. So it's been a long 9 months, and so
yeah, and a few more to go, but
yeah.
But I think also the messaging of vaccine and even seeing nationally the messaging that nursing facilities and staff of nursing facilities, and this morning's news, I was so delighted to see on the national news the discussion of all staff of nursing home, environmental services, nutrition, everybody being included in the first wave of vaccination. I was delighted to see that messaging happening on a national level this morning on the news. So we're all eager. I'm proud to say here at Johns Hopkins, Dr. Morgan Katz, our infectious disease expert in long-term care. Some of you know she's been in your facilities assisting with testing, education, and PPE. She was part of the national committee that's been advising on the distribution of vaccine, a very strong advocate. And I think she really, along with AMDA, the American Medical Directors Association's president, Dr. David Nace, also on that committee, the two of them incredibly vocal and advocating for nursing facilities. And I will also add assisted living, and particularly Dr. Katz has been very vocal about the importance of including assisted living residents and staff, all staff, in the first distribution of vaccination. So I'm very excited about our contributions here in Maryland on a national level. And of course, also vaccine here in Maryland as well, being produced here in Maryland. And so very exciting for all of us, right? Anyone else want to talk about anything that's not gone well with cohorting that anyone would like to say? Anybody have a solution or anybody have a suggestion to help us with? Because I know we've talked about the positives in these sessions, but they'll be most useful if we start tackling the things that aren't going well and brainstorming on those. So is there anything in particular about cohorting or observation that is not going well? Ryan? Anything? I was going to say one of the things that wasn't going well here for me was the fact when we ran out of beds. And it sounds like for some of your facilities, you've already planned ahead so that there isn't a delay in taking that positive resident. But we have been challenged at times with needing to not having a bed immediately for an appropriate observation or a cohorting with positive. Has anyone run up against that yet?
I think we run into that all the time. This is Jim from Columbia. Because just knowing, it looks like you have a bunch of empty beds on your bed board, but then you got to find the right fit and the right situation, for that exact patient. So it's not, your folks at the hospital might think you have a bunch of beds and you could take a bunch of patients, but then you look at exactly what the situation is, what unit they're on, what their COVID status is, if they're in observation. A lot of things come into play. I was going to add, we had to do one thing here at Columbia too, which was we had an earlier outbreak than most, I guess. Several months ago, we had quite a few cases and they were all on one unit that it was two semis, so it was semi-private and a semi-private that shared a commode. So not a shower, but there was a single restroom between the two semis. And that's the unit that was having the most frequent outbreaks. So the decision was made at that point to take all of those semis down to privates. And so that's a long-term care unit. So we had to take 20 beds offline, basically. So they were able to do that because, of course, census was just down in general with a slowdown of admissions. So the total facility census went down. But those beds are staying out of service until there's now future renovations that are complete on an older unit that was taken out of service and now is going to be put back into service with those 20 beds. So not exactly what we're talking about, but it was definitely a significant step to try to avoid spread and create private space.
Mm-hmm. Yeah.
It's Chelsea from Maze. I was going to say too, it's hard for us, like we're so small, like we're 93 beds, but we're mostly semi. So if I have any sort of outbreak, I really have to immediately stop taking admissions in case we have to prepare for, moving people off that unit, because we're not large enough to have, a whole separate wing for admissions, a whole separate wing for PUI, and a separate wing for COVID. That's been a really big challenge. You have to let your kind of census plummet just so you can keep your long-term care residents safe. So that's really challenging.
Oh yeah, absolutely. Yeah.
The hospitals don't like to hear it too. Well, I'm not taking any admissions, and they're like, "Why?" It's harder on you guys, but we got to keep our patients safe.
Absolutely. On that note, I want to share a brochure. I'm going to share my screen, and one of the resources from today's session was developed here at Johns Hopkins Bloomberg School. And I was part of this, and Dr. Katz was part of this as well. And it really is a resource for hospitals on partnering with long-term care facilities. So this is in your programs for today. But I just want to walk you through a little bit of it in these summaries of recommendations. And these were distributed across the nations as part of the COVID biocontainment groups education. But basically, the summary of recommendations are here, and it basically is hospital systems have to have a situational awareness of long-term care facilities, their bed situations, their PPE situations, their testing of residents and staff, and their ability to do just what we just talked about, isolating and quarantining, so working together with hospital systems. And this brochure, all of these recommendations that were put forth here, then were part of our governor's task force in COVID and led to our current Maryland COVID-19 hospital SNF partnership grants that are bringing us together for these reasons. And I was part of these meetings here at Johns Hopkins where we talk about patients awaiting SNF beds and talking about these partnerships so that we could have a system of healthcare that extends from emergency room to acute hospital to post-acute care and back to the community effectively, recognizing the constraints. We here at Bayview are one of the few hospitals left in this area that have semi-private rooms. And we had the same challenges that you're all experiencing in your nursing facilities because we could, we turned a whole medicine unit into COVID once we had enough patients that they could share these rooms. But it was a real struggle to decant our emergency room with, and just as you said, putting patients in PUI appropriately, in COVID positive appropriately, and non-COVID units when they were here for other reasons. So we had those same challenges, and respect what you've been dealing with. So I wanted to share this brochure. As early in the pandemic, April, this was published, but really did lead to hospitals across the country understanding the importance of what we just talked about. And it even included recommendations here. I'll show you recommending have a dedicated telephone hotline and email so that skilled nursing facilities could communicate effectively with hospital teams. So, okay. Any other comments on cohorting? Any other creative strategies in choosing your cohorting units? I love the idea of the old cafe being a great space for opening into a COVID unit. Good. We were really challenged here when we needed more ICU beds and having enough of an entryway for appropriate donning and doffing of PPE before entering our ICUs. We ended up building a tunnel. It was really interesting to see what our what happened with our environmental services and our maintenance folks trying to keep staff safe coming and going from our intensive care unit. So we all get creative. All right, I'm going to move into the section of quality improvement. I'm going to share my screen again. Oh, and let me just ask We have Dr. Victor Boguslavsky with us from IHI. Victor, any comments you'd like to make on our discussion of cohorting and observation units?
Thanks so much, Michelle. And again, thanks everyone. I think it's a great conversation, really. And what I have been following and hearing is there's a lot of success and seems like fewer challenges. There are some areas for improvement, maybe, so that will be good to maybe follow up over the next weeks or so, just to hear about the plan sort of steps for improving. But I also feel like there should be some sort of a success story written about this. There's a lot of successful practices that would be worth sharing with the IHI community. Then including this document that you have just shared, Michelle, is this on the IHI's community work?
It is.
Excellent.
It's part of session 3's planning. And but when I saw it there, I was so delighted to see it, since we had been part of the authorship and down here in Maryland, and the facilities on this call today are all part of these relationships and here in Maryland with our hospital partnership grants by the state of Maryland. Very exciting. All right, thanks.
Excellent. Yeah, particularly for the new cohort that I've going to be getting soon to the session 3. To everyone, I think it's an excellent document. And again, I'm just simply underscoring the importance of your writing about, I know you're all busy, but writing some sort of a success story about this was extremely helpful and a great learning for all of us. Thank you. Thanks.
Good.
Appreciate it.
Good. The last part of today's session will be on conversations to prepare for improvement. Our quality improvement section for today is really how conversations can be leveraged to support improvement work, and really that one-on-one conversation, the huddles. Throughout our discussion, we heard repeatedly how huddles are an effective form of communication for staff to share their concerns and for staff to problem solve together. So in some ways, I feel that you folks, again, are ahead of things. And I think really you're doing this. You're supporting your staff. You're tapping into the creativity of your staff. We talked about the fact that the morale for many of our staff on COVID units actually is higher than the non-COVID units, because there is this sense of teamwork. We're here for a very important reason. At the end of the day, we have made a difference. And we're finding ways to build a more robust system. And we just heard about renovations happening. And I know here at our own hospital, as we're beginning to do some COVID, some of the things I talked about for COVID upgrades, we may not go back to semi-private rooms in some areas after COVID. This is just talking about lining the pathway and getting us prepared. But the pillars for staff supporting, I think, are here. Staff want to be heard. They want to be cared for. They want the preparation and support. And they want to know that the leadership of the facility has as a underlying principle the importance of protecting staff and residents together. In the Hear Me section, these small huddles that we've just heard about, questions being asked. What concerns do you have today? At the end of a shift, what didn't go well today? What might we need to take to leadership to improve? And always supporting what good things happened today. That celebration we heard about, it sounds unusual to say I'm celebrating the fact that we identified a new admission with COVID, but in fact, we're celebrating the fact that new admission did not spread it to other long-term care residents of the facility, because they were identified so rapidly and appropriate PPE being used to protect staff. So that's what small huddles can quickly establish. Oops, sorry. Active listening. Hearing, here's what I hear you say. So we call it also teach back, but active listening is something so that we're always rephrasing and regrouping and coming to consensus. And here's one of the guidebooks from the IHI to support staff well-being during the COVID pandemic. That's part of our resources in this program. I like this little recommendation, and perhaps we might take this back and discuss this at the beginning of next week's session, just briefly to debrief on this topic. But speaking to 5 staff members and asking them the same version of questions. What concerns do you have for your residents, yourself, or your team? Are there steps we can take right now as a team? And what good thing happened today? So let's try next week. If maybe each group here would take maybe one of these questions and speak to 5 staff members, and then report back next week as we start next week's session on these important, crucial conversations for staff well-being. Any comments on those, on that topic of huddles? Has anyone tried this already, or are you doing this every day and this is just part of your routine? I think we heard earlier today that it is part of most of your day-to-day operations as you begin your shift huddles and finishing for the day and signing out. So, all right. So let me go, I'm going to share my screen one last time for today. And let me just sign out of that. And we're just going to finish up by reviewing today's topics. So today we really did, rather than look at the CDC's video, basically everything that's in that 20-minute video, you're already doing from what each facility has reported. You've shared with us some of the challenges of putting together a cohort unit based on bed availability. Creative ways of choosing your facility, choosing within your facility the locations of cohorting units and observation units, how you're messaging to your residents and your family members on these new procedures, and how you're getting the job done efficiently and effectively in a time when there's so much we're doing all at once. This team is in the trenches and problem solving, and you're using the quality improvement strategies that I just outlined with the use of effective staff communications with one-on-one conversations and supporting the staff through hearing their concerns and problem solving. So with that, I think I'm going to ask if there are any last minute comments on today's session. And hearing none, I want to be sure that everyone has the resources from the IHI. So I will be sending out to this group an email summarizing these resources, making sure you have access to the website for the IHI. It includes all of these videos are right there. So if there is someone in your facility you want to show or you yourself want to see them, there's just quick access to all of this information. You don't have to spend time looking for all of it. It's right there on the IHI's website supporting this program. So I'll be sure and make sure you all have that access and you're using it. So I'll end by saying for next week, then we'll start with a little debriefing by hearing about your experiences by sharing those 3 questions with 5 members of your staff and hearing some of the responses that you've gotten, okay? So with that, I'll say, have a safe week. I know we're all busy in our trenches and continuing to do the great work we are, and we're just one day closer to vaccination and look forward to that day we can celebrate that together. So with that, I'll say have a wonderful afternoon and see you next Tuesday. Bye-bye now.
Thank you
Have
all.
a good
Thank
day.
you.
You too.
Thanks.